HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Associate Professor Khor on interstitial lung disease management. Professor Khor, tell us about yourself.
Hi, I'm Associate Professor Khor from Melbourne. I'm based at the Austin Hospital Respiratory Department and also work at Monash University as a research academic.
Now, today we're going to address an issue that all of us at GPs will see some patients at some stage, but it doesn't seem as if we're seeing many of them. So really, I'll start with very general questions, Professor Khor. What are interstitial lung diseases?
Yeah, that's a good question. So interstitial lung disease is not specific to a single condition. So it's what we call umbrella terms. It covers a whole group of conditions that primarily affect the lung parenchyma as a result of inflammation or fibrosis, or more commonly, a combination of both. And unfortunately, because it's such a mixed bag, so you can see quite varying presentations in terms of clinically and also during the investigation with the radiology.
Now, because it is such a, if you like, big term and an umbrella condition, what are some of the more common ones that we as GPs will probably see?
Okay, I think a good starting point is to think about how we can categorize it. Then it might be easier to manage in that way. So typically, we kind of broadly categorize into interstitial lung disease that's secondary to an underlying cause. And the common things that you might encounter in general practice are those associated with autoimmune disease underlying this, such as rheumatoid arthritis, scleroderma. The patients already have those diagnoses coming in with respiratory symptoms, getting more breathless. Then that's kind of a red flag to say they might have developed extra articular involvement in their lungs. The other common groups that have an underlying kind of causes to it is what we call occupational exposure or environmental exposure. So the common one that is in the papers a lot in the recent years is like silicosis. People working with Caesar stones with exposures to silica, and those of older age, they might have exposed to asbestos when they were younger as part of their work occupation exposure. They can develop at an older age. Some of the kind of weird or exposures that you might come across. For instance, we have a group of patients who have hobbies or pets at home, typically birds exposure. They can develop what we call a group of interstitial lung disease known as hypersensitivity pneumonitis as a result of inflammation due to exposures to the animal proteins. Then they can develop inflammation in the lungs. The other common group that can come across in general practitioner, especially in patients of older age, above 70 years old, who have smoking history, is a group of condition which we call idiopathic interstitial pneumonia. So this is a group of condition where there is no identifier cause. The most common one that you will hear about is idiopathic pulmonary fibrosis. So this is a group that typically affect those aged above 70s, males predominantly, and have a history of smoking in the past or still a current smoker. And this is a group of patients that typically have the worst prognosis out of all the interstitial lung disease that we encounter in clinical practice.
Okay, thank you for that list. I would like to actually start with the last one first, if I may. When you speak about older men who've been smoking for many, many decades, how are we going to differentiate between, say, a man with COPD or actually a new case of interstitial lung disease?
Another very good question, because unfortunately, there's only very limited way the lung can manifest as a symptoms. So the symptoms that patients present with are very similar between patients with COPD versus patients with interstitial lung, idiopathic pulmonary fibrosis, or even compared to people presenting with cardiac disease underlying with ischemic heart disease, which is another common condition in this group of patients. So they typically will have breathless, patients with lung disease, either COPD or IPF or idiopathic pulmonary fibrosis, may have the additional coughing. And the kind of critical discrimination between COPD and ILD, interstitial lung disease or idiopathic pulmonary fibrosis, is listening to the chest. Patients with COPD, you might hear a wheeze or just a very quiet, soft breath sounds. But if you hear crackles, then that's kind of a red flag to say this is not COPD or asthma. This is something affecting the lung parenchyma. Idiopathic pulmonary fibrosis will be one of the different differential diagnoses, as long as there's no kind of clinical signs of fluid overload, which is another common situation that might be encountered clinically. If there's an underlying heart disease causing a bit of pulmonary edema, you might still hear a little bit of crackles at the lung bases. And I guess the critical, when you hear crackles in clinical practice, the critical next step is to differentiate between heart disease versus whether there's underlying idiopathic pulmonary fibrosis or interstitial lung disease. Then there are kind of follow-up tests that needs to be performed. Typically, you will start with a chest X-ray, which is a good way to start, not kind of simple test to perform, not kind of like you don't have to have a long wait list to get to that test, but it's a very crude test again. If there's presence of fluid overload, then that will help you to differentiate between the heart and the lungs. But often you need to follow up with a CT chest to have a better look at the lung parenchyma. And typically we would ask for what we call a high resolution CT chest. So it's a special protocol that can do fine detailed evaluation of the lungs. And they do specific protocols where they get the patient to flip over lying on the tummy so that they can have a good look at the lung bases, where typically idiopathic pulmonary fibrosis or lung fibrosis start from. And the other important test to ask for is lung function test. So the spirometry will be good to differentiate between COPD and IPF or any other ILD. So you see obstruction with COPD or asthma. And then if there's no obstruction, but indeed it shows restriction, then that's another red flag to say, this is not COPD. This is something that affecting the lung parenchyma, interstitial lung disease, or idiopathic pulmonary fibrosis.
Well, that's a fabulous answer because it tells us how to think and what to do. However, there's also a question I have with regard to checking history, not
Yes.
occupational history, but what are some of the specific questions we need to ask the patients? And the second is about the duration or time frame of the appearances of different types of symptoms. Do they help us understand whether it's cardiac, whether or not it's COPD, or one of these interstitial lung diseases?
Good questions. And I think between the symptoms, it's important to ascertain the duration. So I guess with breathlessness, unfortunately, with both COPD and interstitial lung disease, it's often an insidious onset. It's chronic. So you might hear patients having at least months or years of kind of chronic breathlessness or slow decline in exercise capacity, things that they can do a year ago, they can no longer do now, or they become slower overall. And sometimes patients might be attributing that to age, given this age group of patients. But typically, it's a very insidious onset over time. In younger patients, then it might be a more rapid onset, especially in those with connective tissue disease underlying it. So it's important to ascertain the duration. Typically, it will be at least months, if not years. Things that evolve over days, it won't be interstitial lung disease. And typically, heart disease will have additional red flags like chest pain, chest tightness that doesn't occur in interstitial lung disease. So wheezes definitely is not a sign of interstitial lung disease. If you hear patients saying they have also wheezing, and that would kind of hint towards more a obstructive lung disease like COPD or asthma. And cough is the other one that you want to ascertain as well, even though cough can present in patients with COPD, but it's usually not a very prominent symptoms. But patients with interstitial lung disease or IPF, typically they'll have this kind of annoying cough that kind of doesn't go away. They might start with thinking it could be like an upper respiratory tract infection or bronchitis, but they just after courses of antibiotics, it just doesn't go away. They just kind of hang around, can happen any time of the day. There's no typical kind of triggers to it. It can happen at the kind of things that we don't think usually trigger cough. For instance, just having a conversation, eating, it can trigger this cough persistently.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So let me get it right. I have a patient who is generally a little older, not necessarily so if they've got, if you like, the autoimmune diseases, it's a history. But they come and they present with a gradual onset of breathlessness, especially with exertion. And they may additionally have this annoying chronic cough that comes on for no particular reason. And really, apart from asking about whether or not they are at risk of having birds or particular occupations, the one critical thing we must do as GPs is to listen to their chests. What you're saying is, David, the two differentiators are wheezing, which suggests obstruction, or crackles that may suggest a restrictive lung disease. And that's the crackling that should trigger us to actually start to investigate a chest X-ray, one of these high-resolution CT scans, and lung function tests. Is that what you're telling us?
Yeah, definitely. And that you definitely want to listen to the chest, especially at the lung basis, because that's where where lung fibrosis start. It typically affects the lung basis first. And sometimes you might want to make sure that you get the patient to have a cough to clear it, to see whether it could be just kind of collapsed lungs with like whether the patient have just been lying down for a little bit of period before they come to consultation. But if the crackles doesn't go away with cough, that's definitely is a red flag.
What's the use of oximetry in the practice?
So typically we still measure oximetry like at rest in patients coming for assessment to assess for their oxygenations. Like the other thing that I personally like to do is when they first walk into the consultation room, I'll typically pop one on to see what their oxygen saturation is like after mobilizations. That's also a good sign to pick up something is not right. Because patients with COPD, unless they have very severe COPD at a very advanced stage, they don't typically develop exertional desaturation early in their disease. So if they have just been never diagnosed with lung disease, they're just coming in with these new symptoms, typically they won't have desaturation if they have COPD. But if they have but patients with interstitial lung disease or idiopathic pulmonary fibrosis, this is unfortunately a group of patients that typically develop exertional desaturation early because the lung fibrosis and inflammation really interrupt gas transfer. So as a result, these patients, like almost about 50% of patients we see in clinical practice will have exertional desaturation. And ideally, you want to do a 6-minute walk test or exercise test, but that's not always feasible. And the good crude way to look for it is when they walk into the consultation room from the waiting room after a period, like a few meters, what's the saturation is like.
Interesting. And a very useful and simple tip. Now, as a whole, how common are these diseases and what's the natural history of it?
So definitely it's not as common as COPD or asthma. That would be kind of the bread and butter that you see on a daily basis. So it's the exact prevalence is unknown, but it's estimated that around 8 to 10,000 of people living in Australia are affected by idiopathic pulmonary fibrosis by itself, and it will be a bigger group if we take into account all this other interstitial lung disease as a broader group. And for idiopathic pulmonary fibrosis itself, every year we roughly diagnose about 2,000 new cases. So it's with aging populations, we are diagnosing more and more patients, and especially now we have easy access to CT scanner and things. So we are picking up more patients. In terms of the natural history of this group of patients, it does vary substantially depending on the underlying subtype of interstitial lung disease. So as mentioned earlier, idiopathic pulmonary fibrosis is the worst case scenario. it is a condition that's relentlessly progressive. Even nowadays, we do have access to antifibrotic drugs that's available through PBS schemes since 2017. But those drugs only slow progression. Typically, in the past, we would say patients diagnosed with IL, idiopathic pulmonary fibrosis, they will have a median survival of around 4 to 5 years. It is longer now. It's almost like 7, 8 years with the antifibrotic drugs if they can tolerate the medications, but they will still progress on treatment. So it's an unfortunate event. For patients with non-idiopathic pulmonary fibrosis, especially those with connective tissue disease associated interstitial lung disease, they tend to have a better prognosis if we can get control of their underlying autoimmunity with immunosuppressants and catch it early so that they don't already develop fibrosis. That's the crucial point. If they still have inflammation that's driving the interstitial lung disease, it's a good thing because that usually can be managed with immunosuppressants to reverse the inflammations, prevent more lung scarring from developing. But once they have fibrosis, it's like any scar developed in the body. Unfortunately, it's kind of no way back once that's developed.
It's just that, Professor Khor, I just wonder, as a GP, once we make the diagnosis, seeing that there's very little that we can do as a GP to treat these things, how quickly should we refer them?
I think it should always be referred at diagnosis, and then it kind of the next step when they get to the specialist care is usually kind of getting a confident diagnosis of the type of interstitial lung disease patient may have, whether it's idiopathic pulmonary fibrosis, connective tissue disease, hypersensitive pneumonitis, or exposures to work and things like that. And then we typically will work with GP hands in hands, for instance, involving drug treatment. If the patient is initiated on either immunosuppressants or antifibrotic medication, we'll work hands in hands for monitoring the drugs, typically liver function, renal function, the blood count. And unfortunately, all these drugs does have significant potential side effects. So we typically will communicate about that. And the other important components is like working with GP for vaccinations. You want to minimize the chance of catching infections because each time that happens, they can trigger acute exacerbation. And that's really an event that we want to prevent. So we would typically want to get the patient optimized with that. And unfortunately, because it's a chronic conditions like any other chronic conditions, support for psychological, mental well-being, smoking cessation if they are still smoking, nutritional support and advices, and involvement of like what we call pulmonary rehabilitation, referral to exercise and educational program run by physiotherapists to optimize the functional status. So it's a kind of a big group of people that working together to help patients. That's technically not curable.
Now, here's a tricky one because some of the diseases you've mentioned are directly related to the occupation and
Yes.
therefore are probably covered by work cover. And we can imagine that there's going to be a lot of work done to prove it and to support them with the claim. So how do we move forward with this? Are all respiratory physicians very aware of this, and therefore would they be the ones to commence the work cover claims, or is it in the hands of the GP? If it's in the hands of the GP, who are the ones who are going to back us with the evidence?
So typically, it will start with the respiratory physician to get to secure the underlying diagnosis, to get a confident diagnosis, excluding possibility of other kind of differential diagnosis. So typically, that would be initiated from the respiratory physician to provide the letters. Sometimes we may need to go down the pathway of getting a lung biopsy to kind of get the final evidence to say that this is indeed what's causing it. But typically nowadays with better radiology interpretations and scanner, we typically will be able to secure a confident diagnosis that way to avoid lung biopsy, which can be another event that can trigger complications in patients and invasive. So typically will go through a multidisciplinary evaluation in a tertiary or quaternary care. Sometimes we may involve occupational evaluation as well from occupational physician, where they go through thorough workplace assessment to kind of help the patient to secure the work compensation.
This is just such great news for GPs because you can imagine that when we're busy, to do all that is like, oh my goodness, I really don't want to go down this route. And therefore, you might put off the diagnosis for quite some time, or even not even mention work cover because of the hassle. But it is so great to know that you are, if you like, you are going to initiate and follow up the process. And therefore, for us as GPs to refer very early on is absolutely essential.
Yeah, definitely. Because especially with work exposures, for instance, in the case of silicosis, you really want to avoid the further exposure from the early time. And if you refer early, hopefully the patient is at a younger age where we can try to kind of link in to avoid more permanent damage and potentially look at other options for career occupation, which is tricky again, because a lot of the patients, getting them to stop further exposure when there's their source of income is always a tricky discussion.
Now, when they die, do they die of respiratory failure, or infections, or is it more likely to be, say, a cardiac complication? And how many actually end up with cancers, and what sort of cancers do they get?
Yeah, good questions. Another one. So it depends on the underlying ILD subtype. So for patients with idiopathic pulmonary fibrosis, almost certainly they are going to die of idiopathic pulmonary fibrosis. It's an unfortunate diagnosis. It's like so. Typically, this is a group of patients where they will continue to progress even with treatment, and so this is a lot of counseling and diagnosis for this sort of patients and advanced care planning to prevent unnecessary intubation and treatment resuscitation towards the end. For patients with connective tissue disease like rheumatoid arthritis, typically they will have the most common cause of death will be as a result of their autoimmune conditions like rheumatoid arthritis. Some patients can cardiovascular risk is high as well in this group of patients. So idiopathic, like the interstitial lung disease as a cause of mortality is kind of the number two cause of it. If they have along this unfortunate group of patients that have progressive disease. So typically that's why it's important to get a confident diagnosis of the type of ILD. Then you can provide the counseling and discuss with the patient the expected cause and what might happen down the track. In terms of lung cancer, unfortunately, interstitial lung disease itself is a risk factor for lung cancer, particularly idiopathic pulmonary fibrosis, because a lot of this patient also has smoked in the past. So they have kind of this additive multiple contributing factors, and typically they have non-small cell lung cancers.
Okay.
It's the most common type of patients. There isn't a kind of a screening protocol in terms of how often we do lung CTs to identify the development of lung cancer in this group of patients, but you want to monitor for symptoms suggesting of whether there is developing an underlying lung cancers, for instance, if they have kind of a sudden drop in weight, hemoptysis, because lung fibrosis typically does not cause hemoptysis and it should not cause pain. If the patient gets started to develop chest pain, it's another red flag because lung fibrosis doesn't cause chest pain.
Now, the other confounding factor is both acute COVID and long COVID. What sorts of impact is it having on patients with interstitial lung disease?
So patients with interstitial lung disease definitely have worse outcome if they've caught COVID infections. And it kind of, if they recover, the recovery period tends to be very long because it's kind of compound their underlying symptoms already, because fatigue is already a common issue with this group of patients with their reduced exercise capacity and breathlessness. So unfortunately, when they develop COVID infection, it can potentially trigger off further disease progression. They can trigger off more scarring. So we definitely want to optimize their vaccinations. And even though we are kind of not in the peak of pandemic anymore. Unfortunately, we still have a lot of viruses running around. For instance, this year we have a lot of RSV virus that we encounter in hospital admissions. So we still advise patients to practice safety precautions, especially if they are going into busy areas or going into like areas that like traveling in the public transport and things still protect themselves with preventions for catching an infection.
Now, what I'm hearing is that short of informing our patients to be vaccinated for all viral diseases, avoid exposure to various substances, to stop smoking, is there anything else we can do as GPs to try and reduce the risk of interstitial lung disease in the community?
Unfortunately, there aren't any preventative strategies available for preventing interstitial lung disease. I think early diagnosis or early identification is still the key. And like you mentioned, things like harm minimizations with any exposures of concerns, things that you might advise patients, for instance, if they are doing like chemical exposures at home with gardening, which is something that a lot of patients will do nowadays, and home renovation, if they are doing DIY home renovations with a lot of dust exposures at home, then they should be wearing masks to protect themselves, because unlike in the industrial situation where there are now laws to enforce that they have good ventilations and protective measures for their workers, but when people doing DIY renovation at homes and things like that, it's less of a protective environment. So there are things that should be put in place to protect themselves and minimize harm.
Now, I'm just going to go to you for key messages, Associate Professor Khor.
So I think the key messages, there are three. The important ones is always do a chest auscultation for patients coming in with complaint of respiratory symptoms to ensure whether there is presence of crackles of the lungs. If there is present, that is a red flag and should not be left unattended, should follow up with investigations for why the patient has crackles. And interstitial lung disease is on the differential for that. Second is refer early. If once diagnosed interstitial lung disease, where you pick up on the CT chest, or if you have a suspicions based on the clinical assessment, refer early, because you want to get patients treated early to prevent further development and treated as soon as possible. In patients, once they have confirmed diagnosis of interstitial lung disease, then working hand in hand with the specialist to provide a holistic care for patients, addressing their vaccinations, nutritional status, further exposures to potential harmful environment, smoking cessations, and never concerns about getting in touch with their respiratory physician. Actually, we quite like to talk to general practitioner where we can work together and help the patients, especially in this condition where it does have significant symptoms and burden on the patients. And unfortunately, we still don't have a cure.
I just wonder if there are resources that are helpful for GPs, and if so, we will be attaching links to these to the interview itself.
Yeah, definitely. So along with Lung Foundation Australia and Thoracic Society of Australia and New Zealand, we have developed quite a handful of patient information, because this is not a common condition. If you tell a patient you have interstitial lung disease, most of them will be staring blank at you. They have never heard about this before, unlike asthma or cancers, patients who have heard about those terms. So we have developed a whole kind of patient-focused resources and also healthcare professional resources targeting for primary care, general practitioners. That's kind of freely accessible through Lung Foundation Australia website. So I'll be sending the link to David so that can be attached to kind of, you can just bookmarks and then you can just print out. And they can also they also have QR code where you can print out, the patient can scan. If they have smartphone, they can access the information that way.
I thank you for your teaching and for your time, Professor Khor.
Thanks very much. Great talking to you, David.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.